Well, thanks, Roger. It's a great pleasure to be here for the first time. Even though the course has been a pure disappointment for me all along. I haven't been here. This is my first time. I didn't manage to come earlier. And now all the other guys are talking about big surgery and technique. And I can only talk about when to take out the disc. So, no, but I'm really happy about talking to you about this. I think it's a crucial topic, and it may change your practice as well. It has changed mine. My disclosures should not matter in this aspect, I don't think. So the problem was in the past that we had patients coming in with lumbar disc and motor deficit, and anesthesia we would like to do this surgery maybe at night or on the weekend, and the anesthesiologist would say, well, it's just a mild paresis, it's a lumbar disc. I mean, does he have cauda equina? No? Okay, we're not going to do it. And I got so pissed off by this that that it changed our program all the time. The patients were not doing that well, that I told one of my residents some time ago to look into this. And I would like to show you 3 studies that we did in the past few years on the topic. Just as an introduction, normally, when do we do surgery? Very rarely in massive uncontrollable pain for lumbar discs. We know that in the long term, meaning 12 months and later, it doesn't make a difference whether we take out the disc if the patient has only pain. Neurologic deficit, if he has cauda equina, there are some studies out there, and I think nowadays we all consider this a surgical emergency, and we would like to do it within 24 or at the latest 48 hours of onset. And if we do it later, we know that only 40% recover from the literature. And this seems to be quite different if you have a motor deficit. We don't care that much about a motor deficit. And obviously, we would like to do those patients early. But the question is, do we need emergent diagnostics and do we need emergent surgery? And this can be a problem with radiology, as I said, with anesthesia. What do we know from the literature? If you do have a high-grade paresis, grade 3 out of 5 or less, most spine surgeons would actually advocate early surgery. We know this from a study from the Netherlands. And then there are some studies, I just put a few up, some prospective studies that have found no advantage of early surgery, but most patients were treated after 2 weeks, maybe even a month, at least not on an emergency basis. So we looked at and some studies clearly showed, as I said, no influence of timing, but mean duration 30 days. So this is not acute at all. There was one study over the West, also from the Netherlands. They looked at grade 3 and 4 and compared non-operative with surgical, and they found no difference in those patients. But again, the surgical patients were not treated as an emergency. So we've published this paper last year, December of last year, I think, in spine. And what we did, we looked at 330 patients that were recruited in 3 years. So we see about 2 patients a week with this, with an acute motor deficit by a lumbar disc. And the patient usually goes on to get a sequestrectomy. We had a follow-up of 3 months, and we divided those patients between treated within 48 hours of onset and after 48 hours of onset. And I'd like to show you the results. So this is the outcome after 3 months. On the left 3 columns are those patients treated within 48 hours with mild, moderate, and severe deficit. And the right side are those patients treated after 48 hours. And as you can see quite nicely, if you treat them within 48 hours, practically 100% recovery, even in the severe cases, 96% no deficit. If you treat them later, that was an average of 6 days, so not that late if you think about it. And about 1/5 of the patients will remain unchanged. So they will have a severe paresis ongoing after this. And so this is important data. As I said, we published this. Then people talked to me and said, well, that's only because you only follow them up for 3 months. And they'll be much better at 6 months and much better at a year. It just takes them longer to recover. So we obviously did the same thing. We followed those patients prospectively now for an average of 5.1 years. So no less than 3 years. And one of my residents, he was able to actually see all those patients back, except for the 3 that had died. So we had a 99.1% follow-up rate, a very active guy, actually. And so we group those patients now less than 48 hours, 2 to 7 days, and larger than 7 days. And this is the long-term follow-up. Severe deficit. The left side, you see those that recovered completely in black and that had a grade 4 paresis in dark gray. And then it goes on like this, and you see the same thing. Patients treated within 48 hours, full recovery, even with a plegic foot drop. If you treated those patients later than 7 days, no recovery at all. And if you treated them in between, some recovery. And this is the same. So you have a 84% chance of recovery, full recovery, 13% between 2 to 7 days, 0% after 7 days, and no recovery, 0, 11, 100. So this is something that's quite obvious data that we found, and more than 300 patients. Moderate deficit, basically the same results. Little better recovery after 2 to 7 days for those patients with grade 3 paresis, and those patients that actually had only a mild deficit. Those patients did recover also if you treated them within a week. If you had a grade 4 deficit, they were as good. So maybe those are not as critical. But again, even those patients that nowadays, we neurologists consider they don't need treatment urgently because they have a grade 4 paresis, only 72% recovered if you treated them after 1 week. So there will be a permanent, obviously, potentially mild deficit in some of those. Sensory deficit, same results, but that didn't bother the patients that much. So the same is true for sensory dysfunction. If you treat them within 48 hours, full recovery. If you treat them late, very late recovery. So when to operate, what we do now, for moderate and severe deficits, less than 48 hours. If they have a mild deficit, within 7 days, if the mild deficit is disabling. Obviously, we don't worry about if they have just a mild foot drop, it may not make a difference, but if they have a quadriceps paresis, we would also consider them that a disabling mild deficit. The second study we did, I'll be very quick on this. We then said, well, this is a retrospective study. Maybe that's not the right way to do. So we looked at 120 patients within 3 months. 60 patients had a motor deficit, and we looked prospectively at the outcome after 1 year. Interestingly, there were 6 patients with coronary equina syndrome in this 120 patients. If they were treated within a day, full recovery. Those treated after 48 hours did not recover. And you see the same thing, outcome after 1 year, moderate severe deficit, even in the prospective study, same result. Almost full recovery in the early treated patients, very poor recovery in those treated later. And this is, again, same result. We can go through this very quickly. And just to finish almost in time, we now looked at our cervical disc patients. We have less acute motor deficits from cervical disc herniations. So we looked at a period of 5 years or 6 years, 210 patients with motor deficit that we operated, less than 48 hours. Only 32 were treated acutely, 178 were treated after 48 hours. And I'll just show you, because we're still working on the final analysis of this data. It basically shows the same thing, that if you have a severe deficit, you should treat them early. And if you have a mild deficit, it may not make that much of a difference, but it's also true for the cervical spine. So in summary, although early surgery is advocated in patients with significant motor deficit in both cervical and lumbar disc herniations, so far there has been no evidence for neither the acute surgery or emergency surgery, nor a specific time interval. Can you wait 2 days? Can you wait a week? Except for the 48 hours for the coronary equina syndrome. And we found that motor deficits fully recover if decompressed within 48 hours, even if they are very severe. That's why we consider severe and moderate paresis a clear indication for immediate decompression, immediate meaning within a day. Within 24 hours, those patients are treated at our department. And mild paresis should be treated within 7 days if the deficit causes disability. And I think this will potentially, we are currently publishing that later follow-up, and this should affect our treatment of acute discs and also talking to our anesthesiologists about this. Thank you.
question.
Thank you. I'm sure there are a lot of questions. So first, now we just learned we got to operate on everybody with a metastatic tumor, and now we got to operate on every disc herniation. It gets better and better. Yes.
So logistically, when I think about this, I mean, I think it sort of creates some problems, really, for a busy practitioner, because I can only think of two ways where I can actually get a patient into my office within 48 hours. One is they come to the emergency room and I'm on call. The second is if a referring physician calls me up and says, hey, I got a person that just developed a foot drop today, can you see him? Otherwise, my earliest opening for an appointment is within a week if somebody's pushing it. So how do you do it?
I agree. That's a good thing about socialized medicine. In Austria, everybody that doesn't walk properly goes to my outpatient clinic as an emergency case. And that's why we see them. It's very simple. I agree with you. In every other setting, even if you have a very busy private practice, they're not going to be able to see you. But in our system, we see them. And in contrast to in the past, we would send them back, or we would wait for the next week to do surgery on them. And now we just, for us actually it's easier now, because I have data proving my anesthesiologist to do this Saturday morning, rather than waiting until Monday. And so for me it's easier. It's not irritating my OR schedule anymore as it used to in the past. So for us, but I agree with you, this needs also probably education of GPs and everybody, that those patients that have a disabling motor dysfunction should be sent to the emergency room.
And Dr. Thome, as a follow-up to that, how are you guys able to so efficiently do that in Austria? Because I just got back from spending some time in Italy, and there was a massive backlog to be seen by a spine surgeon in particular, not just a orthopedic or neurosurgeon, but a spine specialist. Didn't matter if you had a foot drop or whatever you had, and they thought that it was a problem of social medicine, that they actually were, had an inequality in terms of how many providers, so how many people needed that specialized spine care. And they had a very poor ability to be able to triage those patients unless they came to the emergency room.
Yeah. Well, I have to be careful what I say. There's a huge difference between Italy and Austria. And I love Italy, I love Italians, but the system is very different. And socialized system with not a lot of money is a problem. Austria is a socialized system with a lot of money. And that's why this works quite well. And to be honest, we have a waiting list for OR. So if I see a regular lumbar disc, the patient waits at least 6 weeks for surgery if he has only pain, which means that half of those don't even come to have surgery because they are cured. And so this is the good waiting list. But for those patients with a foot drop or significant motor deficit, they are treated right away.
Gianluca, any comments? Yeah.
Of course, I have to our country. So basically, probably we are not so fast in operating such patients, because of course we rely to our schedule, and but of course they get the surgery for free in a very good way. So that's and of course I think the quality of the care that we have is very high.
Yes.
Ozone. You give ozone.
No, I absolutely agree. It may be different also in Austria. There are differences from center to center, and I think in Italy it's the same. But in our system, actually, it's not a problem at all. But I also know that in Germany it may be a problem to see patients that quickly. So it's.
Yes, we got another final question, comment there. Over somebody else.
That's a great talk. Just wanted to clarify, are these all painless or painful motor deficits?
No, most of them are painful. We are going to look at this also now of those that are painless. To be honest, most of those, if they are treated that early, they are still in pain.
Okay.
And we're not talking about those painless paresis that come and you see them after 2 weeks or something. Sure. We can't really say much on those because we don't have a high number of those in our series.
So what would you do if they presented after 7 days? Any thoughts on that?
That's a very crucial question that we already discussed also in the past. I'm with that data, I'm still more aggressive with surgery than I used to be, because you can see that still a significant proportion does recover, but the rate of recovery is just not as good, and they may recover only by 1 or 2 grades if they have severe deficit, but still that will be functionally relevant. And so we still would be more aggressive if they are absolutely painless. We discussed it with the patient, and to be honest, I don't know the answer.
So just giving them the benefit of doubt.
Yes.
Thank you.
All right. I think we got to maybe while Bill, you want to set up your talk?
Maybe the last one. Just
ask his last.
one final question, may I?
Okay. Now we got here the gentleman from Ghana. We've got a colleague from Ghana who traveled thousands of miles to ask this one question. So let's.
Okay. I'm not going to talk about the waiting period in Africa. I'm not going to talk about that. But what I want to know, the results, did you have some patients who have physical therapy immediately after your surgery?
Well,
those with severe deficits, did they have?
Yes. We would go for, they will have a certain, usually not inpatient, but an outpatient rehab program.
Okay.
With physiotherapy, yes.
So,
well, this would be standard.
Standard for everybody.
Yes.
Okay, thank you.
Great. Thanks a lot. So we'll proceed.